Bismillahirrahmanirrahim. Now moving to the next session, that is the 11th part of our CVS unit. So it is about the coronary. It starts with the coronary steal syndrome. So distal to the coronary stenosis, vessels are maximally dilated at the baseline. Now the concept is that suppose this is the point of obstruction. To compensate for the decreased blood flow, the vessels which are distal to this one, they are maximally dilated already, right? So due to the endogenous metabolite or something, but with all the possible mechanisms, the vessel, the part of the vessel which is distal to the obstruction is already maximally dilated. Now, if in an attempt to increase the blood flow uh, towards this distal area, we give the person some sort of, you may say, vasodilator, right? So when we administer a vasodilator, this area cannot dilate any further, but this area which can dilate becomes dilated, and the blood flow, instead of going in this direction, starts moving in other direction. So this steals the blood from this area and brings it to the normal healthy tissue, which basically does not need it. So this is the phenomenon of coronary steal syndrome. So distal to the coronary stenosis, vessels are maximally dilated at baseline. Administration of vasodilators, for example, dipyrimidine, regadenosone, dilates the normal vessels. Blood is shunted towards the well-perfused area. Ischemia in the myocardium perfused by the stenosed vessels. Principle behind the pharmacologic stress test with coronary vasodilators. Okay, so basically, when we are checking for, if there is some obstruction or not, so we give vasodilators, short-acting vasodilators like adenosine, I guess, and we check for the stress test. It is basically when the people cannot do the treadmill test, or they cannot do the physical activity because of any reason, like because of an amputated leg, or maybe they just can't do it. So we do the pharmacologic stress testing like this. Then we have sudden cardiac death, SCD. Death from cardiac causes within 1 hour of onset of symptom is called as sudden cardiac death. Most commonly due to a lethal arrhythmia like ventricular fibrillation, which is associated with the coronary artery disease in up to 70% of the cases, cardiomyopathy, hypertrophic and dilated, hereditary ion channelopathies like long QT syndrome and Brugada syndrome. Brugada syndrome is more common in schizophrenic patients. Prevent with implantable cardioverter defibrillator, that is intracardiac device. Myocardial infarction, most often due to rupture of coronary artery atherosclerotic plaque that will lead to acute thrombosis. Increased cardiac biomarkers CK, and troponin are diagnostic. Commonly occluded coronary arteries are left anterior descending artery, then right carotid artery, then the circumflex artery. So this is a sequence. Symptoms are diaphoresis, nausea, vomiting, severe retrosternal pain, pain in the left arm or jaw, shortness of breath, and fatigue. The CVS, okay, how much time does it take for the cardiac muscle to stop after the onset of total ischemia? That is 1 minute. Like within a minute, the cardiac muscle stops contracting. The other changes, they happen later on, but the instantaneous cessation of contractility happens within 1 minute. If restoration of blood is less than 30 minutes, reversible contractile dysfunction, that is myocardial stunning, contractility will gradually return to the normal over hours to days. Like if there was return of blood flow within 30 minutes, so the cardiac myocytes will not start beating immediately after return of blood flow. They will be stunned. They will be shocked by what happened. But then within a couple of hours or days, they will start contracting at the normal pace. But that is true if the restoration happens within 30 minutes or less than 30 minutes. If restoration takes after 30 minutes, total ischemia becomes irreversible. So the coagulative necrosis, I don't think it is. The coagulative necrosis starts like within first day, and there will be eosinophilic and black discoloration on day 1. Then neutrophil starts infiltrating from day 1 to 3, from 1 to 3 days, and the tissue will look paler. Macrophages will come from 4 to 7 days. Then after a week, the granulation tissue will form, and after 1 month, the scar will be formed. Cytoplasmic hypereosinophilia, it is not eosinophils, it is eosinophilia of the cytoplasm, is one of the earliest signs of coagulative necrosis of the myocytes. Neutrophilic activation will lead to fibrinous pericarditis. This happens in 1 to 3 days of of this thing, of what is this called, of myocardial infarction. There can be fibrinous pericarditis, which can be felt as sharp pain, increased with coughing, swelling due to irritation of the posterior pericardium, radiating to the neck due to irritation of the inferior pericardium to the phrenic nerve. Macrophage activation will lead to phagocytosis, and that it is the time frame from 3 days to 14 days where the risk of rupture is highest. The free wall rupture can happen. If that happens, it can lead to cardiac tamponade. If the rupture of interventricular septum happens, interventricular septal rupture can happen if we are if there is some obstruction in the right coronary artery. Interventricular septal. No, no, no. The interventricular septal rupture can occur if there is some obstruction in the left anterior descending artery, lead artery. So that can result in VSD or shunt. Holosystolic murmur at the left sternal border 3 to 10 days post MI, and papillary muscle rupture. Now these two ruptures can occur because of lead obstruction, and this third type of muscle can occur because of obstruction of the right coronary artery. This will result in mitral regurgitation. Holosystolic murmur at the apex radiating to the axilla 3 to 10 days post MI. So time after the myocardial infarction, predominant light microscopic changes. From 0 to 4 hours, there will be minimal change. 4 to 12 hours, early coagulative necrosis, edema, hemorrhage, and wavy fibers. From 12 to 24 hours, coagulation necrosis and marginal contraction band necrosis will be seen. In 1 to 5 days, coagulation necrosis and neutrophilic infiltrate will be seen. 5 to 10 days, macrophage phagocytosis of the dead cells. From 10 to 14 days, granulation tissue and neovascularization will be seen. 2 weeks to 2 months, collagen deposition and scar formation will be present. Now this is another good, this is a page from first aid, although we are reading first aid, but this is a elaborate book. So 0 to 24 hours, there will be no, in first 4 hours, no changes visible, but then if we are taking the window to 24 hours, then there are visible changes. So the occluded artery, this is the infarct, dark mottling, pale with tetrazolium stain. So light microscopy, early coagulative necrosis, release of necrotic cell content into the blood, edema, hemorrhage, wavy fibers, neutrophils will appear. Reperfusion injury is associated with the generation of free radicals, which leads to hypercontraction of the fibers through increased free calcium channel, calcium influx. Complications in this time frame are ventricular arrhythmias, heart failure, and cardiogenic shock. In 1 to 3 days, there is neutrophilic infiltration. So there will be hyperemia and gross pathology, and on microscopy, we'll find extensive coagulative necrosis. Tissue surrounding infarct shows acute inflammation with neutrophils. And post-infarction fibrinous pericarditis is the risk here. In 3 to 14 days, hyperemic borders central yellow-brown softening, maximally yellow and soft by 10 days. Macrophages, then granulation tissues at margin. Pre-wall rupture leads to tamponade, and papillary muscle rupture will lead to mitral regurgitation. If we have a free wall rupture, that can lead to cardiac tamponade. If we are having papillary muscle rupture, that can lead to mitral regurgitation. Interventricular septal rupture due to macrophage mediated structural degradation. Left ventricular pseudoaneurysm, risk of rupture. From 2 weeks to several months, the artery is recanalized and the infarcted area looks gray to white, and it is contracted scar will be formed. And Dressler syndrome is an autoimmune condition, because when there was some infarction to the heart, to the cardiac myocytes, the proteins or the antigens which were normally inside the cells, they spill out into the circulation, and autoantibodies are formed against them, and they can then lead to Dressler syndrome, heart failure, arrhythmias, true ventricular aneurysm, risk of neurothrombus. Then we have reversible injuries to the cardiac muscle. Firstly, there will be ischemia. Ischemia will act on the mitochondria, and there will be decreased oxidative phosphorylation, decreased ATP. When there is low ATP, there will be decreased sodium pump, increased influx of calcium, water, and sodium, and increased efflux of potassium. Endoplasmic reticulum swelling, cellular swelling, and loss of microvilli and blebs. Increased anaerobic glycolysis. So when there is increased anaerobic glycolysis, so the glycogen will decrease. Increased lactic acid will decrease the pH, and there will be clumping of nuclear chromatin. Detachment of ribosomes will lead to decreased protein synthesis. Myofibril relaxation, the early sign less than 30 minutes due to the anaerobic glycolysis. Disaggregation of polysomes will lead to dissociation of ribosomal RNA from the mRNA and decreased protein synthesis. Disaggregation of nucleus, clumping of nuclear chromatin due to decreased pH, and triglyceride droplet accumulation due to decreased lipoproteins. There will be glycogen loss early due to the decreased ATP. Mitochondrial changes include swelling, which is reversible due to decreased ATP, decreased sodium potassium pump activity, and increased intercellular sodium and calcium. Vacuolization will lead to irreversible cell injury, which indicates that the mitochondrion is permanently unable to reduce the ATP. Contraction bands located at the margin of necrotic area caused by the reperfusion of the irreversibly damaged cells. So basically, that will cause calcium influx and hypercontraction of the myocardium. So basically, the problem is that the contraction bands are located at the margins of the necrotic area, and when there is infarction, so sodium and calcium are accumulating inside the cells. On top of that, when the blood will start flowing to that direction, more calcium will enter the cells because of the damaged membrane and increased permeability of the cells towards ions. So calcium will enter and that will cause hypercontracture, and that will be visible as contraction bands. Post-infarction ventricular remodeling. Remodeling is defined as an alteration in the structure, dimensions, mass, shape of the heart in response to hemodynamic load and/or cardiac injury in association with the neurohormonal activation. Following myocardial infarction, stretched infarcted tissue increases left ventricular volume, leading to combined volume and pressure load on non-infarcted zones and mixed concentric and eccentric hypertrophy. An increase in end-diastolic volume occurs early in MI to accommodate a larger preload and compensate for the acute decrease in contractility after MI. Area of infarction lead to expansion, thinning, and regional dysfunction. The rest, hypertrophy to compensate. Net result is dilated ventricular hypertrophy with enlarged left ventricular cavity. It can be prevented by ACE inhibitors or some beta blockers. So post-MI remodeling in acute infarction looks like this. Then infarct zone thinning and elongation. Spherical ventricular dilation is happening, and this is the fibrous scar and myocyte hypertrophy, increased interstitial collagen. Diagnosis of myocardial infarction on ECG, the gold standard for MI diagnosis in the first 6 hours. ECG changes can include ST elevation, STEMI, transmural infarction, ST depression, non-STMI, non-ST elevation myocardial infarction, and subendocardial infarction, hyperacute, peaked T waves and T wave inversion, new left bundle branch block, and pathologic Q wave or poor R wave progression evolving or old transmural infarcts. Cardiac enzyme, cardiac troponin I rises after 4 hours, peaks at 24 hours, and increase for 7 to 10 days, more specific than other protein markers. CKMB rises after 6 to 12 hours, peak at 16 to 24 hours. It is predominantly found in the myocardium but can also be released from the skeletal muscles. Useful in diagnosing the reinfarction following acute MI because levels return to normal after 48 hours. Yeah, so the cardiac troponin I, it is it gives us an early diagnosis and it is more specific for MI, but it cannot detect reinfarction. CKMB is more sensitive and it also helps us. It also tells us about the reinfarction because its level drops down in 16 to 24 hours. Its level drop down comes to normal at 48 hours, and if there is reinfarction after that, so we can detect by an elevated level of CKMB maybe at 72 hours. So that will tell us about reinfarction. ECG localization with STEMI. So this lead localization is very important. So firstly, there are 3 main leads: lead AVR, AVL, and AVF. Then lead 1, 2, and 3, and these are the leads. So in right-sided heart failure, the lead 2, 3, and AVF, they will have specific changes, right? Then we have these leads like V1, V2, V3, V4, V5, V6, and AVL. These are the leads which are associated with the branches of left coronary artery. So this is the crude way of knowing it. Like lead 2, 3, and AVF, if they are obstructed, so there is some blockage in the right coronary artery, and if lead V1 to V6 along with 1 and AVL, they are obstructed, so there is some problem with the left coronary artery. Now for further subdivision, these 3 leads, if there is some problem in them, it means that inferior infarction is happening, like inferior myocardial infarction is happening, because this is the lower surface, inferior surface of heart, which is supplied by the right coronary artery. If lead V1, V2, V3, and V4 is having some problem, it means that left anterior descending artery is obstructed. If lead V4, V5, V6, 1 and AVL is having problems, it means that circumflex coronary artery is having some obstruction. Now let's go into the details. Now they're saying in anterior MI, like this one, anterior MI, the blocked vessel is left anterior descending artery, and ECG leads involved are some or all the leads from V1 to V6. Maybe till V4 or maybe all till V6 they can be obstructed. Inferior MI, this is inferior MI in these things. The right coronary artery or left circumflex artery, depending that which of these two arteries is giving the posterior descending artery. So in such situations, we'll find an ST elevation in the lead 2, 3 and AVF. Then in posterior MI, that is, what is posterior MI? In posterior MI, same thing is true, like either left circumflex artery or right coronary artery, depending on the dominance concept that which artery is giving the posterior descending artery. So in the posterior MI, there will be ST depression in lead V1 to V3. In these three leads, there will be ST depression. Okay. ST elevation in lead 1 and AVL if it is left circumflex artery that is blocked, and ST depression in lead 1 and AVL if it is right coronary artery. Okay, that's kind of tricky or maybe a thing to cram, but it's important. If it is left circumflex artery, then ST elevation in 1 and AVL will be present. If it is if it is right coronary artery, then ST depression lead 1 and AVL will be present. If it is lateral MI, then left circumflex or diagonal artery and diagonal artery is obstructed. So we will find ST elevation in lead 1, AVL, V5 and V6. So whenever a left circumflex artery is involved, lead 1 and AVL will have ST elevation. And ST depression in lead 2, 3 and AVF. Okay. So these are counter leads, like one and if lead 1 and AVL is having ST elevation, so 2, 3 and AVF will have depression. So yeah, right ventricle MI occurs in half of inferior MI. So the problem is right coronary artery and ST elevation lead V4 to V6 are very present. Okay, the Uworld point is that diabetes mellitus increases the risk of MI by 3 times. What can be the complication of myocardial infarction? They are very important. So the first complication of myocardial infarction is cardiac arrhythmia. It occurs within first few days after myocardial infarction, and it is an important cause of death. So basically it happens within first few days, and the range is within few hours to few days, and it is basically abnormal rhythmic activity like ventricular fibrillation or something like that, and that can lead to death before reaching the hospital within first 24 hours post MI. Post infarction fibrinous pericarditis, it occurs 1 to 3 days after the MI, and there will be a friction rub, papillary muscle rupture. So the most immediate complication that can occur leading to sudden cardiac death is cardiac arrhythmia. Then can be pre-infarction, post-infarction friction pericarditis, which looks something like Dressler syndrome, but you must remember that Dressler syndrome occurs weeks to months later. Why so? Because Dressler syndrome is a pericarditis that is caused because of an autoantibody mediated reaction, and antibodies take at least 2 weeks to get formulated, right? So it is not Dressler syndrome. In first 1 to 3 days, post-infarction fibrinous pericarditis can occur, which will have similar presentations to Dressler syndrome or pericarditis. Then papillary muscle rupture. It can there are 3 types of rupture: papillary muscle rupture, interventricular septal rupture, and ventricular free wall rupture. So these 3 ruptures can occur in the window of 3 to 14 days. So papillary muscle rupture occurs 2 to 7 days after MI. If it occurs, posterior medial papillary muscle, most common to rupture due to single blood supply from the posterior descending artery, and in most of the people the posterior descending artery is originating from the right coronary artery. Okay, can result in severe mitral regurgitation because one of the papillary muscle that was holding the mitral valve is now no more there, so there will be regurgitation. And other causes of papillary rupture are bacterial endocarditis, but this is not related to the MI. It is one of the other causes of papillary muscle rupture. Interventricular septal rupture, this can also happen in the 3 to 5 days window after MI, and it is basically due to the macrophage mediated degradation of the that will lead to ventricular septal defect, increased oxygen saturation and pressure in the right ventricle. Then ventricular pseudoaneurysm formation, it occurs 3 to 14 days after the MI because Pseudoaneurysm means that there's ballooning out, like the cardiac tissue, infarcted tissue is ballooning outwards. Now, the scar tissue is formed at least 14 days after, right? So at least 2 weeks, it takes 2 weeks to form for the formation of scar. Now, once the scar is formed, it is strong enough that it will not rupture, but yes, it can balloon out. So it contained okay, so it is pseudoaneurysm. I'm sorry, it's not false. It is a false thing. True aneurysm is over here. A pseudoaneurysm is the one in which there is where is that? It is contained free wall rupture. Like suppose this is the cardiac wall. All three layers are not rotating, but there is a defect, and between the I guess pericardium or epicardium and the heart, there is a accumulation of the blood. So this is contained free wall rupture. There will be decreased cardiac output. There is a risk of arrhythmia and embolus from the mural thrombus. Then comes the ventricular free wall rupture. Again, occurs within 5 to 14 days after MI. There will be free wall rupture, and that will lead to cardiac tamponade. Left ventricular hypertrophy and previous MI protect against the free wall rupture. Acute form usually leads to sudden death. Then comes the true ventricular aneurysm. Now occurs 2 weeks to several months after MI when the risk of rupture is no more there. It is an outward bulge with contraction that is dyskinesia associated with fibrosis. Then we have Dressler syndrome. It occurs several weeks after MI and autoimmune phenomena. That is an important thing to remember, resulting in fibrinous pericarditis. Then left ventricular failure and pulmonary edema can occur secondary to left ventricular infarction, ventricular septal defect, free wall rupture, papillary muscle rupture with mitral regurgitation. Okay, then we have mechanical complications of acute myocardial infarction. So these are the mechanical complications. Let's read the names first. Right ventricular failure, papillary muscle rupture, interventricular septal rupture, free wall rupture, and left ventricular aneurysm. So what is right ventricular failure? The time course is acute, involved coronary artery is right coronary artery. If the right ventricle is not functioning, there will be hypotension, the lungs will be clear, and there will be cosmal sign. It will be similar to the right heart failure. So basically if it is right-sided heart infarction, so these symptoms will be there, and echocardiogram will show a hypokinetic right ventricle. Papillary muscle rupture acute within 3 to 5 days. Involved artery for the papillary muscle because it is a posterior medial papillary muscle which is ruptured in most situations. So the blood vessel is right coronary artery. Clinical findings are severe pulmonary edema and new hollow systolic murmur. There will be severe mitral regurgitation with flail leaflets. Then we have interventricular septum. It is also happening under acute settings within 3 to 5 days. Left anterior descending artery or right coronary artery, that is basal septal artery, will be affected. Chest pain, new hollow systolic murmur, biventricular failure and shock. Left to right ventricle is shunt and increased oxygen level from the right atrium to the right ventricle. Then we have free wall rupture within 5 days or up to 2 weeks. Left anterior descending artery is affected. The symptoms include chest pain, shock, and distant heart sounds. Pericardial effusion with the tamponade will be the echocardiogram finding. Then we have left ventricular aneurysm. It happens after several months, and again left anterior descending artery is the culprit, and subacute heart failure and stable angina will be the symptoms, and thin and dyskinetic myocardial wall will be evident. Okay. Common complications acute myocardial infarction. So reinfarction can occur within hours to days. Ventricular septal rupture hours to 1 week. Free wall rupture hours to 2 weeks. Post-infarction angina occurs hours to 1 month. Then papillary muscle rupture can also occur between 2 days to 1 week. Pericarditis 1 day to 3 months. If it is happening 1 day, it is post-infarct fibrinous pericarditis. If it is happening later than 2 to 3 weeks, then it is Dressler syndrome. And left ventricular aneurysm 5 days to 3 months. There the Uworld found that SLE may cause an acute coronary syndrome at a young age, even with angiographically normal coronary arteries. Special complications with MI. Firstly, inferior MI. Inferior MI means the right coronary artery is obstructed, and we will see the problem in the lead 2, 3, and AVF. So, right ventricular infarction, loss of right ventricular contractility. So, when the right ventricle is not contracting, you know that this is the this is the heart, and this one is the right ventricle. So right ventricle is connected to the superior vena cava, which is then connected to the brachiocephalic veins, and brachiocephalic vein is connected to the external brachiocephalic vein, subclavian vein, and external carotid vein, and that is connected to the jugular veins. Yep, and internal carotid and something, if I'm not wrong it wrong. But yeah, so the manifestations of changes in the atria, right atrium, is evident in the jugular veins. So we can examine that and we can visualize that. So loss of right ventricular contractility, there will be elevated jugular venous pressure with clear lungs. Decreased preload to the left ventricle will lead to hypotension. Sinus bradycardia and heart block will be there. Hemodynamics include increased right atrial pressure and central venous pressure, decreased cardiac output and pulmonary capillary wedge pressure. Diagnosis is with the right side chest leads. Okay, so we have ST depression in the leads 1 and AVL, which are reciprocal changes. Okay, so basically, when we have right-sided heart failure, the main thing that you must remember is ST elevation in the lead 2, 3 and AVF with Q waves, because Q waves are pathologic finding of the STEMI, right? ST elevation MI has Q waves as well, but ST elevation will be seen in the lead 2, 3 and AVF. The reciprocal changes will be seen in the lead 1 and 2, 1 and AVL, that is there will be ST depression. ST depression in the leads 1, V1 and V2 is also seen, right? And for the heart block, 2 PVS followed by a QRS complex. So 2:1 heart block is present, which is morbid type 2, right? Morbid type 2, there is no PR prolongation, but just there is skipping of the heartbeats. Okay. So this is the placement of the leads. This is the left side, this is the right side. So they have placed all the leads on the right side. If we are suspecting right-sided heart failure, so we perform a right-sided ECG. So we have placed these leads in the 4th and 5th intercostal space. In the 4th intercostal space on the left side, V1R, then V2R 3, 4, 5, 6. So like 4th and 5th intercostal space is having all the leads, and the right atrium, midclavicular line, medial line. Okay. Then we have left main, left MI. I think it was left MI that is what they were supposed to, right? So ST elevation in the lead AVR, and there will be diffuse ST depressions. AVR. What does that even mean? This is lead AVR. Okay. So they are saying that there will be ST depression in lead AVR. Yes. There is ST. No, there is ST elevation in the lead AVR. And then there will be diffuse ST depressions. Now that is what I can't understand. What does that mean? Okay, I have no idea about this one. So moving forward, chronic myocardial ischemia. So firstly we have hypernating myocardium. 9. So this thing was left main coronary artery occlusion. I just Google that. So if there is a occlusion in the left main coronary artery, there are two things that you must remember. Firstly, that this occlusion is not going to be a complete occlusion. If the left main coronary artery is occluded completely, we will not find time to have an ECG. There will be certain cardiac, right? But if it is partially occluded, so the pattern that we will be having is that ST elevation in the AVR will be evident, and there will be diffuse ST depressions, because the left main coronary artery is supplying the most of the anterior and lateral aspect of the heart. Yes. So that is why we have diffuse ST depressions in all the leads. Most of the leads, the only thing lead in which we are getting ST elevation is the lead AVR. Listen. Now these things are making sense to me. Why is there ST depression? The very first thing that I told you is that the complete occlusion of the left main coronary artery will lead to death, right? Sudden cardiac death. So if we are talking about left main coronary artery occlusion, that is partial, right? Now we have talked about partial occlusions. That if I come all the way over here, it was way back. But when we were talking about the concept of ST depression and ST elevation, so we said that if it is transmural inflammation, if there is transmural infarction like this one, so ST elevation will be there. If it is only subendocardial infarction, so ST depression will be there, right? So that is why there is diffuse ST depression, because there is subendocardial infarction because of partial occlusion of the left coronary artery, right? So as far as I can understand this, the problem is that because of partial occlusion of the left coronary artery, there is ST depression diffusely in all the leads. Like you can see ST depression here, here, here. The only lead with the ST elevation is the lead AVR, this one. And I think this is reciprocal change because the lead AVL is having ST depression. So as a reciprocal effect, this one AVR is having reciprocal elevation, maybe, but I think there can be a better explanation somewhere. So I will try to do that in the medicine sessions, inshallah. So moving forward, now we have chronic myocardial ischemia. So what is hibernating myocardium? Now, as the name indicates, hibernating myocardium, it means that the myocardium has been suffering from the ischemic insult for a very long time. Like there is reduced blood flow to the myocardium for a longer period of time. So there are some cells which are not responding or not contracting as avidly as they used to be. So they have just undergone a hibernating or sleeping state. So it is a state of chronic myocardial ischemia in which both myocardial metabolism and function are reduced to match a concomitant reduction in the coronary blood flow. Due to moderate to severe blood flow limiting stenosis, this new equilibrium prevents the myocardial necrosis. Chronically hibernating myocardium demonstrates decreased expression and disorganization of the contractile and cytoskeletal proteins, altered adrenergic control, and reduced calcium responsiveness. Mechanism: decreased energy metabolism, but there is sufficient ATP to prevent the contracture. Increased gene expression of tumor necrosis factor alpha and nitric oxide synthase, that is inhibitors of contracture. Okay. Decreased energy metabolism, there is sufficient ATP to prevent contracture, and increased gene expression for TNF alpha and nitric oxide. Both of these things prevent the contracture. These changes lead to decreased contractility and left ventricular systolic dysfunction. However, a coronary revascularization and subsequent restoration of the blood flow to hibernating myocardium improves the contractility and left ventricular function. What is ischemic preconditioning? It is a phenomena in which brief repetitive episodes of myocardial ischemia followed by reperfusion protect the myocardium from subsequent prolonged episodes of ischemia. In clinical terms, repetitive episodes of angina prior to myocardial infarction can delay the cell death after complete coronary occlusion, therefore, provide greater time for myocardial salvage for the coronary revascularization. Like normally we have 30 minutes, right? We have to salvage the myocardium within 30 minutes. But if the person had repeated myocardial infarction previously, so now the myocardium is preconditioned to anoxic conditions. So maybe the time limit is now 45 minutes for us, like in such a person, in contrast to the person who had the first episode of angina that culminated to infarction. So in those people, we have a lesser time in comparison to the preconditioned people. What is the concept of myocardial stunning? Stunning, as the name indicated, is like a person is in shock or he is astounded, right? So less severe form of ischemia induced reversible loss of contractile function causes brief ischemic episode less than 30 minutes followed by reperfusion. Repetitive stunning can lead to hibernation. So stunning mean like there was Prince metal angina, I suppose. There was complete occlusion of the coronary artery, and within a minute the heart stopped contracting the musculature of the heart, and then after a while it came back. Like it was reperfused, but it doesn't. After reperfusion, the myocytes do not start contracting immediately. They are stunned. They are they're too shocked that what happened. Oh, so that brief reversible loss of contractile function is called myocardial stunning. Then we have differential diagnosis of chest pain. So differential diagnosis and feature of chest pain: coronary artery disease. For the chest pain, these are the differentials: coronary artery disease, pulmonary or pleuritic, pleurisy, pneumonia, pericarditis, and pulmonary embolism. Aortic causes like dissection and intramural hematoma, gastrointestinal or esophageal, or musculoskeletal. So the coronary artery disease presentation will be substernal chest pain, radiation to the arm, shoulder, or jaw. It will be precipitated by exertion and relieved by rest or nitroglycerin. Pulmonary or pleuritic, that is pleurisy, pneumonia, pericarditis, and pulmonary embolism, it will be sharp, stabbing pain, worse with inspiration, pericarditis worse when lying flat, pulmonary embolism and pneumothorax, respiratory distress and hypoxia will be there. For aortic dissection and intramural hematoma, sudden severe tearing pain which radiates to the back, elderly men, and hypertension and risk factors for atherosclerosis will be present. For the gastrointestinal and esophageal pathologies, the presentation is that it will be non-exertional and relieved by antacids. It's a big clue. Upper abdominal and substernal pain. It will be associated with regurgitation, nausea, and dysphagia, and there will be nocturnal pain. Chest wall and musculoskeletal, so there will be persistent or prolonged pain, worse with movement or change in position, and often follows the repetitive activity. Peripheral vascular disease. What are the clinical features of peripheral artery disease? The etiologies are atherosclerotic risk factors like diabetes, hyperlipidemia, hypertension, smoking, and age more than 70. The clinical features, it is asymptomatic in about 50% of the cases. Physical examination findings are weak or absent peripheral pulses, bruise on auscultation, poor wound healing from impaired perfusion, cool, pallid skin, prolonged capillary refill, shiny atrophied skin with missing hair, and ungual dystrophy. Common clinical patterns include ischemic muscle pain with activity, alleviated by resting, and erectile dysfunction. Intermittent claudication. That is a characteristic feature of peripheral artery disease. So it is like muscle pain which occurs with exercise and remits with rest. Okay, it is just like stable angina but in the peripheral parts of the body. Thigh claudications, suggestive of occlusive disease of ipsilateral external iliac artery or its more distal branches, for example, common femoral. This is the most common occluded branch, by the way, common femoral, superficial femoral, profunda femoris arteries. Accompanying impotence and or gluteal claudication suggests more proximal aortoiliac occlusion. So if the occlusion is in the thigh, so it means that the external iliac or the distal branches are occluded. If it is also associated with the impotence, so it means that more proximal branches are involved, like aortoiliac occlusion, so-called Leriche syndrome, which in addition to affecting the external iliac artery also diminishes the blood flow to the internal pudendal and the gluteal branches of the internal iliac artery. So this is thigh claudication because of the occlusion of external iliac artery, and here we have thigh claudications with gluteal claudications and impotence in the Leriche syndrome. So this is aortoiliac occlusion and superior gluteal and internal carotid artery, and okay, correct. Then we have cardiomyopathies. So the cardiomyopathies, this is the normal heart. Here we have the dilated cardiomyopathy in which the heart, specifically the left ventricle, dilates. And hypertrophic cardiomyopathy is the area in which there is hypertrophic obstructive cardiomyopathy. HOCM is the one in which there is disproportionate hypertrophy of the interventricular septum. But hypertrophic myopathy, I guess it is, we have talked about this only, but I don't know if they're talking about hypertrophy of the left ventricle alone. But for the myopathy part, I remember that it is the interventricular septal hypertrophy that is called as hypertrophic obstructive cardiomyopathy. Let's read that. Dilated cardiomyopathy, dilation of all four chambers. It's not just ventricle, it is dilation of all four chambers of heart. Most common cardiomyopathy, 90% of the cases. I'm sorry for this, but it is the dilation of all four chambers. The causes are often idiopathic or familial. Genetic mutation, usually autosomal dominant mutation in the dystrophin gene. Other etiologies include alcohol abuse, wet beriberi. It is ABCD, ABCCCD. Okay, so alcohol abuse, wet beriberi, Coxsackie B viral myocarditis, chronic cocaine use, Chagas disease, and doxorubicin toxicity. It is anti-cancer drug. Hemochromatosis, sarcoidosis, thyrotoxicosis, and peripartum cardiomyopathy. There was a sketchy sketch which elaborates all of these causes very beautifully. Findings are heart failure, that is eccentric hypertrophy and systolic dysfunction, and there will be S3 heart sound, slushing heart sound. Why so? Because if the heart is dilated, it is not contracting properly, and blood is pooling inside it. And when new blood will enter, so it will produce a slushing sound, that is an S3 sound. Systolic regurgitant murmur will be there. Why will be a regurgitant murmur be there? Because the walls are moving apart, and so will be the valve cusps. So when they are not adherent to each other, there will be regurgitant movement. So there will be systolic regurgitation, either mitral regurgitation or maybe tricuspid regurgitation. Chest X-ray will show a balloon appearance of the heart. Echocardiography, dilation of all four chambers and biventricular failure. Treatment is with the sodium restriction, ACE inhibitors, beta blockers, diuretics, digoxin, intracardiac defibrillator, and heart transplant. What is dystrophin? Dystrophin normally links the internal myocyte cytoskeleton with the external basement membrane. Remember that dystrophin mutations are also found in common skeletal myopathies like Duchenne and Becker muscular dystrophies. So these dystrophies are also a risk factor or also a causative factor of dilated cardiomyopathy. Doxorubicin dilated cardiomyopathy. It is cumulative and dose dependent, presents many months after discontinuation of the drugs, prevented by dexrazoxane, iron chelating agent that decreases the oxygen free radicals produced by the doxorubicin. Then we have hypertrophic cardiomyopathy. So in hypertrophic cardiomyopathy, this is a normal heart, and this is the hypertrophic cardiomyopathy. Thickened septum further obstruct the left ventricular outflow, and we have anterior mitral leaflet shifts towards the aortic valve. Now the problem is that the outflow tract, if I could zoom it in, so this is the outflow tract for the blood to leave the left ventricle, right? Now this interventricular septum is thickened. On top of that, the anterior leaflet of the mitral valve, it becomes adherent to this thickened interventricular septum. So both of these things, they obstruct the pathway. Now, if we want to, it produces a crescendo decrescendo murmur, which is pansystolic. Now, if we want to decrease the murmur, we can do two things. We can either increase the preload or we can increase the afterload. If both of these things are increased, the symptoms and the murmur will be decreased. Why? If we are increasing the preload, it means that more blood is entering the heart, right, from the lungs back to the. So if more and more blood is entering the heart, the walls will move distant apart, and this tract will be cleared, and more blood can flow to the aorta. That is the phenomena by which the preload can decrease the symptoms. If we are increasing the afterload, it means that suppose we are doing hand grip maneuvers or something. So if the afterload is high, so more blood will be accumulated in the left ventricle before leaving the heart. I hope you could make the point clear. Like, it will take more pressure to be exerted by the ventricle, and to exert more pressure, more blood have to be pooled inside the left ventricle. So when more blood is present in the left ventricle, it will clear. Again, the walls will move apart, and the outflow tract will be cleared, and this will lead to decreased symptomatology. Moving forward, let's see what they have to offer. What they are telling us: massive hypertrophy of the left ventricle cause. And this is a beautiful picture on gross pathology. You can see that this is the interventricular septum, and there is a massive hypertrophy of the left ventricle. Causes usually due to genetic mutations, autosomal dominant mutation in the genes encoding sarcomeric proteins such as myosin binding protein C and beta myosin heavy chain. The clinical features include decreased cardiac output. Left ventricular hypertrophy lead to diastolic dysfunction, that is, ventricles cannot fill. Marked ventricular concentric hypertrophy, sarcomeres are added in parallel, often septal predominance. There will be syncope with exercise. Subaortic hypertrophy of the ventricular septum results in functional aortic stenosis. Sudden death due to ventricular arrhythmia. Hypertrophic cardiomyopathy is most common cause of ventricular fibrillation in the individuals younger than 30, the most common cause of sudden cardiac death in young athlete. Findings: in dilated cardiomyopathy, we were having an S3 heart sound, right? It was S3. In hypertrophic cardiomyopathy, we are having an S4 heart sound, and there will be a systolic murmur. We may see mitral regurgitation due to impaired mitral valve closure. Now, the problem is not that the valves are too apart. The problem is that this distended interventricular septum is, the anterior leaflet of the mitral valve is adherent to this thickened interventricular septum, which makes the regurgitation possible. Okay. So yeah. So biopsy will show myofiber hypertrophy with a disarray and fibrosis. Treatment is cessation of high intensity athletics, because the classical case scenario, the vignette which they will give you in the step exams or maybe anywhere else, is that there is a 20 years old or maybe very young guy who was playing some soccer or some athletics, who was into athletics, and he just died suddenly, and there was a family history of an uncle who died with a similar symptom. Or maybe they can tell you that there's a sportsman, young guy, who is having some sort of systolic murmur, and his paternal or maternal uncle died of similar situation at a very young age. So that is a diagnosis of hypertrophic cardiomyopathy. Use of beta blockers or non-dihydropyridine calcium channel blockers, for example verapamil, and intracardiac defibrillator if the patient is high risk. Physiology of hypertrophic obstructive cardiomyopathy. Asymmetric septal hypertrophy and systolic anterior motion of mitral valve will lead to outflow obstruction, dyspnea, and possible syncope. Other causes of concentric left ventricular hypertrophy are chronic hypertension and Friedreich ataxia. What is the murmur of HOCM or hypertrophic obstructive cardiomyopathy? The degree of left ventricular outflow tract obstruction and intensity of the murmur varies based on the left ventricular and the diastolic volume. Mechanisms that decrease preload or afterload will decrease the left ventricular chamber size. They will decrease the separation between the mitral valve and the interventricular septum and thus increase the obstruction and the murmur will be exaggerated. Sudden standing from the sitting or supine position, Valsalva with the standing phase of that or nitroglycerin administration decrease the preload and they will result in increased murmur intensity. You must remember these things and they're important. In contrast, squatting from a standing position, like you were standing and then you went to a squat position, sustained hand grip or passive leg raises will increase the preload or afterload and thereby decreasing the murmur intensity because they will be increasing the left ventricular and diastolic volume and increasing the chamber size. So, effect of maneuvers on the hypertrophic cardiomyopathy. Valsalva straining phase, abrupt standing from sitting or supine position, and nitroglycerin administration. These three things will decrease the preload and increase the murmur intensity. Sustained hand grip, squatting from standing position, and passive leg raise. Sustained hand grip increases the afterload. Squatting from standing position increases afterload and preload, and passive leg raise increases the preload, so they will decrease the murmur intensity. Now, this is non-obstructive type of hypertrophic cardiomyopathy, and this is the obstructive type. Hypertrophic cardiomyopathy can be of two types, obstructive or non-obstructive. So if it is obstructive, then it will have all those pesky murmur findings and stuff like that. So this is interventricular septal hypertrophy and systolic anterior motion of the mitral valve. During systole, it moves towards this one, interventricular septum, and thus obstructs the left ventricular outflow tract. Okay. Moving forward, medications that generally should be avoided in the patient with a hypertrophic cardiomyopathy. So these includes vasodilators, like vasodilator dihydropyridine calcium channel blockers, nifedipine and amlodipine. We can give non-dihydropyridines. They are good for us because non-dihydropyridines will act on the heart itself, right? They will decrease the heart rate and thus the left ventricular and diastolic volume will be increased. But the dihydropyridines should be avoided. Do not give dihydropyridines in hypertrophic cardiomyopathy. Then nitroglycerins and ACE inhibitors, which decrease the systemic vascular resistance, leading to decreased afterload and lower left ventricular volumes. Diuretics, which decrease the left ventricular venous filling, preload, and also results in greater outflow obstruction. In contrast, negative inotropic agents such as beta blockers, metoprolol, non-dihydropyridine calcium channel blockers like verapamil and disopyramide reduce the LVOT obstruction and are helpful in symptomatic patients with a hypertrophic cardiomyopathy. In addition, beta blockers may also help reduce the anginal symptoms by decreasing the myocardial oxygen demand. Then we have a Uworld point that beta myosin heavy chain mutation lead to hypertrophic cardiomyopathy. Cardiac cell cytoskeletal mutations with mitochondrial enzyme mutation will lead to dilated cardiomyopathy, and third of the cases are autosomal dominant. Okay. Then hypertrophic obstructive cardiomyopathy with harsh systolic murmur due to systolic anterior motion of the anterior leaflet of the mitral valve of the interventricular septum, which is bulged by the asymmetrical enlargement, so that will lead to outflow tract obstruction. Normal morphological changes in the aging heart include the following. First is decreased left ventricular chamber, apex to base dimension. So like this is the apex to base dimension. Like this is apex and this is the base. So that dimension is decreased. This is the normal young heart. This is the old heart that is decreased. Secondly, development of sigmoid shaped ventricular septum. The ventricular septum, I think it is not depicted in this picture, but that becomes sigmoid shaped. Myocardial atrophy with increased collagen deposition. As you can see that there is increased collagen deposition in these areas. This is sigmoid shaped septum. Okay, so this may be. And then we have accumulation of cytoplasmic lipofuscin pigment, that is white cardiomyocytes will be there. Okay, so these are the red cardiomyocytes, and here you can see that these are somewhat white cardiomyocytes because of deposition of lipofuscin. Okay, so then the Uworld point is lipofuscin, yellow brown pigment in the myocyte of in the myocytes of old age people due to the product of free radical injury and lipid peroxidation. Then we will continue with the restrictive cardiomyopathy in the next session. So until then, Allah Hafiz, be amanullah, and take care.